Hello, everyone. I hope that everyone hears me. Uh, I would like to, dear moderators, dear colleagues, I would like to share our experience with femtosecond laser-assisted posterior lamellar keratoplasty, and I would share Russian experience with our femtosecond laser. So, endothelial dystrophy of the cornea is a disease associated with dysfunction of its posterior epithelium. Prevalence of endothelial dystrophy is increasing each year due to the increasing number of cataract surgery procedures all over the world. The most common methods of graft preparation for posterior lamellar keratoplasty is the technique using mechanical automatic microkeratome. This technology is quite simple and widely spread. 44% of all cornea transplantation procedures in USA are performed by side technique. Usually, transplant is being procured in the eye bank and provided to the clinic. However, disadvantages of using mechanical microkeratome are well known. Transplant thickness is difficult to predict, and it is well known that only transplant thinner than 131 micrometer provides highest visual outcomes. Also, there is quite high possibility of perforation during the second cut. The transplant is often irregular. It has thick edges, which provide risk of dislocation in postoperative period and induce hyperactive shift, about plus 1.5 dioptries. The alternative to mechanical microkeratome is femtosecond laser. The most common way of using femtosecond laser for creating a transplant is applanation of laser interface from the anterior sides. But this way doesn't allow to make a regular transplant because the interface makes the anterior surface of the cornea flat, but it makes the posterior surface irregular. And the lamellar laser cut, which is absolutely flat, is being done in the posterior surface of the cornea, which is deformed by the interface. And it provides irregular transplant and not high visual outcomes. The maximum BSRA which you can achieve with this type of surgery is 0.5. The alternative is applanation of laser interface from the posterior side of donor cornea, which allows to make regular transplants. So for this research, we used a femtosecond laser, which was made in Russia. It's high frequency system with repetition rate higher than 1 GHz. The video represents a procedure of preparation transplant from the posterior side of the cornea. You can see the direct applanation to the endothelium. The procedure is controlled by video camera. The applanation is really gentle and its diameter about 9 millimeters. And this real-time video represents that all in all, it takes not more than 20 or maybe 30 seconds for preparation transplant. And the procedure is really simple and predictable. So it's done. Transplant surface evaluation had been performed by atomic force microscopy. The control group was graft created by mechanical microkeratome. Average roughness mean square was evaluated. Statistical analysis showed that femtosecond laser forms a transplant surface of the same high quality as mechanical microkeratome. Also, endothelial cell loss evaluation in vitro was performed. Femtosesond transplants were the main group, and the control group was cornea scroll rims of the same donor. We used 5 pairs of eyes and live dead cell assays. Calcium AM is a blue one, and it represents live and early apoptosis cells. Propydiamidite is a red one, and it represents dead and late apoptosis cells. So AC loss associated with femtosecond laser transplant creation was about 12.5%. Also, we have evaluated the isolated applanation of laser interface for 30 seconds. The control was the same, intercorneal scroll rim. So 14% of endothelial cell loss we have got in this research. And we can conclude that the main reason of endothelial cell deaths during the transplant preparation is the applanation of laser interface. And the laser itself doesn't affect too much. Also, the comparative evaluation of AC loss was also performed, and the control was ultra-thin transplants created by microkeratome. AC loss in femtosesond group was 13.4% and 10.4% in microkeratome group, and statistical analysis didn't show any significant difference between these two groups. So we could conclude that the AC loss is equal in femto and microkeratome group in vitro. So all in all, 32 femtosecond procedures were performed. The observation period was 3 years. The video represents the decimeter axis technique, which allows to remove the DM of the recipients. Usually it's quite a predictable technique, and almost always it is possible to remove the DM by single piece. The transplantation is being performed through corneal incision 4.5 millimeter with boozing glide, and the graft is being unfolded by the irrigation flow and fixed by air. This technique is also suitable for difficult cases. This is the patient with implanted artificial iris and Achmed valve, and you can see the strong retrocorneal membrane, which is really hard to remove. You can also use scissors. The dissection of residual stromal bridges after femto dissection is quite simple, and blunt instruments are always used. You don't need any sharp instrument. And the transplantation may be performed through the corneoscleral incision in some special cases. And the transplant also can be unfolded. Of course, Achmed valve is not your best friend during this type of surgery, but if you use 2 hands and irrigation flow, you can unfold the transplant. It is possible to fix it and make a centration. So at 3 months observation period, in 28 cases, transplant engraftment were observed. In 4 cases, primary graft insufficiency was observed and keratoplasty was performed. I would like to point that we didn't require a single rebubbling. At 1 year observation period, in all 32 cases, transplant engraftment was observed. Transplant thickness in central zone was about 82 micrometers. Host donor complex thickness in the central zone was 550 micrometers, which correlates with the rates of healthy human cornea. In 1 year observation period, maximum achieved BCVA was 0.8, medium astigmatism was 1.35, and atheliothel loss was 31%, and ACD was about 1,500. At 2 years observation period, maximum achieved BCVA was higher, it was 1.0. At 3 years observation period, all corneas were still clear. So let me please conclude that femtosecond laser allows to create an ultra-thin transplant with thin edge, with regular surface and without any risk of perforation. And femtosecond surgery technique allows to minimize risk of dislocation of the transplant in postoperative periods. AC loss is comparative to TSAC, and it provides quite high visual outcomes. Thank you very much for your kind attention.